Welcome back to the Healing Energy Collective. Today, I'm honored to be joined by Dr. Jerold Kreisman, a leading expert in the field of borderline personality disorder and the author of numerous books, including I Hate You, Don't Leave Me, one of the most widely read books on BPD. Borderline personality disorder is something we're hearing more and more about, especially on social media where conversations around self-diagnosis and mental health labels are growing. But BPD is often misunderstood and oversimplified. In today's episode, Dr. Kreisman helps us cut through the noise and better understand what BPD really is, how it shows up in relationships, and how it differs from things like anxious attachment or simply loving intensely. We'll also explore how experiences of BPD can differ between men and women, and talk about the concept of a favorite person and splitting that comes up so often in online spaces. Whether you're curious about BPD for yourself, supporting a loved one, or just interested in learning more about mental health from an expert, this episode offers clarity, compassion, and hope. Let's dive in. Thank you for being here, Dr. Kreisman.
Glad to be with you.
For those who may not be familiar, could you briefly describe and explain what borderline personality disorder is and how it typically presents?
Borderline personality disorder is one of the more common of the 10 defined personality disorders. And it describes individuals who tend to see the world in extremes of black and white, right or wrong, good or bad, all or none. And this kind of viewpoint tends to influence how they respond to their environment, how they respond to situations, how they respond to people. They may love beyond measure those whom they will come to revile without any impact. Individuals with this tend to have significant changes in mood. They may go from one extreme to the other in a matter of seconds. An individual may get a compliment from a respected person and feel joyful and ecstatic, and then minutes later, they may get a certain disappointment and then descend into gloom. They tend to have a sense of internal emptiness, feelings that there's just lacking a substance. The mood changes can involve suicidal feelings, suicidal thoughts and threats. Sometimes there can be tendency to cut on oneself, self-mutilating, not for the purposes of really trying to kill themselves, but for trying to feel something. Most of these people do get better over time, but there is a 10% possibility of suicide among those with this diagnosis. They also tend to have difficulties with concerns about abandonment. They fear being left, but they also rebel against feeling enmeshed or over involved. They have a tendency to have outbursts of rage, way out of proportion to what can happen to stimulate it. They may be impulsive in destructive kinds of ways, involving substance abuse or binging and purging or promiscuity. And all of this, of course, it also is going to involve how they relate to individuals. Relationships are often very troubled, and there is often a sense of an instability of identity. They can be very chameleon-like, which makes the individual very adaptable. They may fit in very well when they're a Democrat. They feel like they're a Democrat when they're with Democrats, a Republican when they're with Republicans. But when it's 2:00 in the morning and they're all alone, they're not sure what they believe in or who they are exactly. Occasionally, it can even, the anxiety that goes along with all of this can also sometimes lead to dissociation and even paranoid thinking sometimes.
And how does this disorder develop?
Well, there are all sorts of theories about that. There, of course, appears to be a certain amount of nature and a certain amount of nurture. Many individuals have, although not all, but many individuals, around maybe 3 out of 4, have a history of trauma. in their earlier life. Um, Oftentimes, their parents may have similar kinds of symptoms. There also appears to be a very high genetic proponent. And indeed, if an individual has a defined diagnosis of borderline personality disorder, a first degree relative is 4 times more likely to also get that diagnosis than in the average population. So it can be probably a combination of things. There does appear to be genetic predispositions that studies have shown, but also sometimes a history that can add to it.
In recent years, I've seen that many people on social media have begun self identifying or self diagnosing with BPD traits. What are the risks and potential benefits of this trend?
I think there really are both. Um, for many individuals, there has been a sense of relief because sometimes, in fact, the name of one of my books is called Sometimes I Act Crazy. There are people who thought, am I crazy? I lose control of my feelings. I don't know why I get so mad. I don't know why my moods swing. And for many people, there's a sense of, oh, you mean there's a name for this? This is actually a syndrome. This is something maybe I can work on to make better. Other people, though, it can become something like a badge. Don't bother me. I'm borderline. And you so often hear it in a derogatory way. It seems like everybody's first wife was borderline. Our first husband was borderline. Um, as a way of a put down, as a way of saying, well, they're crazy. And that's how they're often portrayed when you see examples in the media when it's identified as borderline. But most are not violent. And many have very appealing features. Even though they're often stigmatized in ways, many individuals with borderline personality disorder are successful in their careers. They're intelligent, they're creative, they're spontaneous, they're interesting, um, they're fun, um, and can be exciting to spend time with. Um, but sometimes they're portrayed in ways that make it sound much worse.
People often describe those with borderline personality disorder as deeply magnetic or alluring in relationships. Why do you think that is?
Why they're magnetic in a relationship?
Hmm.
I think they can be very appealing. They can also become very clingy and dependent. Um, so often, uh, someone with borderline personality, because of that all or none kind of what we call splitting, the tendency to split their views into all good or all bad, um, they will find that their initial response to a relationship or a situation or a job or something is, this is the greatest thing that ever happened to me, and they cling to it. But then when there's certain flaws come in, um, it becomes the worst thing. It's hard for people with borderline personality to develop a sense of gray, a sense of nuances, the sense of understanding that there's somebody I really care about, and some things they do just piss me off sometimes, but I still like them. I disagree with their political stance or something, as opposed to I either have to love them or I'm going to end up hating them.
And how would you know if you just have certain borderline traits, such as intensity of those emotions or anxious attachment and loving intensely, versus actually having the full diagnostic criteria?
Well, I think, generally, I think if it's distressing enough, it's something for them to seek help with and let the clinician decide. Although, the way we define medicine in general and psychiatry in particular is in this categorical kind of way, which in a way is sort of all or none. If we're defining blood pressure, it's the numbers, and it's either you either have it or you don't have it. If the numbers go down, if you have diabetes, you have the number or you don't have the number. Well, we have categorical symptoms, and if you have enough of these, you have the diagnosis. If you don't have 5 of the 9 defining criteria for borderline personality disorder, well, then you don't have the disorder. And I think what we're moving towards in terms of defining what it is more of a sense of how severe is it? How interfering with your life is it? So that the issue doesn't become a matter of do I have it or I don't have it. The matter is more a concern of what sort of symptoms of mine get in my way, interfere with my enjoying life, or interfere with my relationships that I can do something about. And I think that becomes more the cogent issue.
Like more on a spectrum.
And I think the future DSMs, the next DSM is probably going to take into account that
Mm.
the spectrum part and more of a dimensional sign of things.
Can you speak to more about how BPD shows up in relationships and why it's so challenging?
Um, I think usually it is an expression of extreme in the lack of consistency, so that there is a string of relationships that all seem to go bad. There's maybe a stream of jobs that start off great and then seem to go bad. And I think that becomes a clue that an individual is having difficulty functioning in those areas, or there may be um, a pattern of behaviors where um, the individual begins to notice, gee, I'm overreacting. I'm yelling at these people for these little things. I think it becomes more a matter of recognizing that there's a pattern that's getting in the way, that it isn't the rest of the world. Uh, it's part of this is me.
And the term favorite person comes up a lot online when people talk about the BBD. What does this dynamic really mean? And can you explain how it impacts a relationship? I know you spoke to how those with the disorder might feel a little bit more clingy and attached.
Um, well, this sort of stereotype relationship for someone with borderline personality and um, would be a, let's say, a woman, and most of those who are diagnosed with borderline personality disorder, 3 out of 4 are women, although that is probably artificial. Most experts now believe that it probably emerges in the population about 50-50, but more women seek treatment. um, some of the symptoms are usually more attributable to female than men. A man blowing his cork might be written off, whereas a woman is seen as maybe something else, or the moodiness may be seen as more feminine. And I think all the other reasons because there's much more pressure in our culture, in our society, on women, especially about identity, whether they're professionals, whether they're when they become mothers, wives, and how all that goes together, much more than pressures on men. But in the classical sense, a female borderline patient will be attracted to a narcissistic male. That's sort of the marriage made in heaven. Because from her standpoint, here's this big, strong guy who seems so confident and he's wonderful. And every time I praise him, it bolsters him up. And he looks at, and then of course his view of her is here's this pretty little girl who's had all these bad relationships because a big, strong man like me wasn't taking good care of her. Someone who's perfect like me who can do all these wonderful things. And so they tend to glom together. And um, that works for a while until the the borderline woman begins to feel overwhelmed and feeling like she's getting too pressured. He wants me to change my hairstyle. I don't want to change my hairstyle. And then the man begins to feel she's not doing what I need to do. She's not letting me control her the way she should. And then things blow up.
Is this dynamic in that same way where you're attracted to what's opposite of you?
Um, Sometimes that can happen, but it usually, again, will occur in paradoxical kind of ways, where it may be a matter of like, well, I'm attracted to him, but he's an alcoholic, and I'm going to fix him. I'll get him to stop drinking sometimes, and because I'm not an addict, but I'll help him, and that can begin to blow up as well. Um, the but the paradox always gets in the way. I was once seeing a couple, and during the session, the wife said to the husband, you don't show me affection anymore. You don't hug and kiss me over, lately. And I miss that. And the husband says, you're right. You're absolutely right. I've been really tied up at work and I have been ignoring you. And that's wrong with me. And I'm going to try to change it. And he leaned over and hugged her. And she pulled away and said, "Oh, you hug too tight." So you have that kind of push pull so much of the time.
And when does it usually implode? Like how long does it usually take before that realization sets in?
That really can vary. Um, it really depends on to what degree the fear of abandonment is more significant than the fear of being overwhelmed. And sometimes, of course, these relationships may go on for a while where both are really being miserable. And other times it can really blow up. And that's where you hear the thing where uh, the person, explains it by saying, "But I really love her," as if that makes it all okay. The fact that she mistreats me or makes me unhappy.
How does borderline personality disorder and narcissism relate to one another? Because I do see similarities in both, where it comes from a deeper place of trauma and then it impacts their relationships in adulthood and beyond.
There can be some spillover. And in fact, a lot of personality disorders do have sort of common sort of symptoms. Typically, most people kind of when they're talking about narcissistic personality, usually there are some exceptions. They're usually talking about somebody whose self-esteem, like someone with borderline personality, is very fragile. However, their way of dealing with it is to cover it over with artificial kind of encouragement that can block out any kind of contradiction of the fact that I remain um, wonderful. Um, for the borderline person, there also is some of those concerns too, but they're more willing to recognize it and reach out for ways to cover it over from other people. Um, so there are those kinds of overlap, but ways of coping with it might be different.
So the way that they get their needs met is different.
Usually, yes.
And what guidance would you give to someone who realizes that they may have more of those borderline personality traits and they want to build healthier relationships? They don't want to be stuck in this dynamic.
I think usually getting some professional help can certainly be useful, of course, in terms of identifying the specific kinds of areas. And there are a number of treatments that have been shown to be useful there. I think it's also helpful to have a partner or family member or friend with whom they can confide and who can also let them know when things are maybe going to an extreme.
And could you share the SET framework for communicating with those with BPD and share other guidance on how partners can meet their partner if they do have the BPD?
Um, yes, uh, one of my books is called "Talking to a Loved One with Borderline Personality," that talks about the dilemmas of the no-win situation, the kind of thing that no matter what you do, uh, the woman says to the man, "Does this dress make me look thinner?" If he says yes, she's going to say, "Oh, so you think I'm fat?" If he says no, you look fine all the time, she's going to say, "Oh no, you don't care about me at all." Those kinds of dilemmas. Um, and for that, um, I attempted to put together kind of a system of communication, not a treatment, but for a loved one to kind of interact with someone with borderline kind of features. And I call that SET, standing for support, empathy, and truth. And the paradigm attempts to allow the individual who's working with the borderline individual to keep in mind those three elements when they're communicating. The support element is an I statement that says, I care about you. I want to help you. I'm in your life. I want to be in your life. I'm someone that you can count on. The E statement is an empathy statement, an acknowledgement of the borderline individual's pain. It's not sympathy. I don't feel, it's not, I feel sorry for you. It's an acknowledgement that you must be hurting a lot. It's a you statement. What you're going through is awful. It must be horrible for you. It's a recognition of that this is not just something simple, that it's hard on this individual. And the T stands for truth or reality, the part that says that we've identified a problem, now we have to deal with it. And what I found is that when one of those three elements is missing, you get feedback from the individual with borderline that really tells you what's missing. If the feedback you're getting is something like, you don't care about me, you're just doing this because you have to, you're just in it for the money, you have some ulterior motive. They're not getting enough of the support element. They're not getting enough of the S part. If the feedback is, don't try to tell me, you don't know how bad this is, you don't know what I'm going through, you can't possibly understand this, then they're not getting the E sense, the empathy part. And you never, ever, 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 ever say to a borderline individual, oh, I know just how you feel. They'll hit you right between the eyes. Says, you don't know how I feel. You'll never know how I feel. It's horrible. And when the truth element is missing, there may be a false sense of you're going to take care of me, and things actually may go really too well for a little while because the borderline individual begins thinking, well, it's all going to be okay. I don't have to worry about it. So that support and empathy without truth is going to end up eventually in a conflagration of blowing up. And of course, truth without support and empathy is sort of a kind of a perverse form of tough love. Snap out of it. It's not that bad. Quit feeling sorry for yourself and get going. And this is an attempt just to keep in mind how you can keep the communication going and hopefully respond to the borderline responses that can just sort of keep you in the game with them and hopefully maintain the relationship.
So, is the truth a request or is it feedback? What is an example of the truth?
I think an example of the truth is after I've said I'm here for you, after I've recognized that this is a terrible dilemma for you, the truth really is saying, what are we going to do about it? We can't just sit here with this. We have to address the problem. We can't just let it fritter away. Here are some options. Here's what we can discuss. How are we going to confront the problem?
And this framework helps those individuals with borderline get out of more of the black and white and into the gray, into the problem solving.
That can be part of the goal there. Um, in terms of trying to recognize that it doesn't have to be overwhelming, that they may have help in dealing with it, and that it doesn't have to be an all or none kind of solution. Because again, the set approach is particularly helpful when you're getting these damned if you do, damned if you did, don't
Mhm.
no win dilemmas where yeah, I'm going to go kill myself, leave me alone. And so you come over. I said, I told you not to come over. Why are you doing this? Well, you said you're going to kill yourself. No, well, but I also told you don't come over. I mean, that kind of thing, saying, look, when a person says they feel suicidal, a person's going to respond to that. Dealing with the truth part of this is reality. This is what people do in situations. In that example where you're in this no-win kind of thing, no matter what you say, they're going to be mad at you.
And when these issues come to a head, I've also read that those with borderline do something called splitting. Could you speak a little bit more to that?
Splitting is a really a psychoanalytic term that basically is describing it's a primitive defense mechanism that is basically describing the all or none kind of thing. Children grow up with that. We read bedtime stories to children. We don't. There's the evil queen and there's Snow White. We don't say to the child. We don't deal with nuances in childhood, and borderline personality, in many cases, is still stuck in that time. It would be confusing for a child to sort of say, well, the evil queen had a tough childhood. Her dad was never around. And Snow White's hanging around, and she's in the same house with these seven little short guys. Is that what's about her reputation? And the nuances are not there. In splitting, they tend to just be good. There's the evil queen and there's Snow White, and that tends to progress into adulthood. Theoretically, some people feel that it has to do with certain parts of development in the infant around 2 or 3 years old, when they begin to separate from mother and begin to identify a separate identity and begin to recognize that they can love mom, but mom can yell at them, and there can begin to develop some nuance.
And how does either side repair when splitting happens?
Well, for the individual with borderline symptoms, I think beginning to recognize that tends to happen. Joe, it seems like everything is either wonderful or terrible. You said that about the last job and the two jobs before that, and you said that about the last three girlfriends. Something else is going on. For the other person, I think sometimes that's where the set can come in. And again, part of the truth is saying, I know some things I do annoy you, and I understand that, and I'm trying, but that doesn't mean I'm all bad. I still care about you, and even though I got mad at you, I know I raised my voice, I yelled at you, I still care about you. And splitting sometimes can also involve another primitive defense mechanism, what's called projective identification. And that can happen, especially when there are outbursts of rage that can happen with BPD. And so um, the borderline person gets angry, they start pushing the other person's buttons, then the other person raises his voice, and the borderline person says, I'm not the one who's angry, you're the one who's angry. Projective identification is basically saying, is in borderline personality, is I'm denying that I'm angry, I'm denying that I have splitting, I'm projecting on you. And if I push enough buttons, I can maybe bring it out in you, and then I can say, it's you who's doing that. And I can hold on to my black or white thinking. So recognizing that part of accepting that maybe it is part of them and not just all projected onto the other individual that you're communicating with.
And so when splitting happens, it doesn't necessarily mean it's the end of the relationship. There can be repair in there.
No, no. And that, I think, is one of the other myths about borderline personality, is the vast majority, and by majority, I mean in the 90th percentile, get better. It can take, even without treatment, many mature out of some of the symptoms. But over years, more than 90% get much significantly better. Some of the symptoms may persist to a lesser degree. Many of these people would no longer fit the defining criteria for borderline personality, which requires 5 or more of the defining 9 criteria. Maybe now they have 3 of the defining criteria. So technically, they no longer have that diagnosis. So the vast majority do get better. So a lot of time it's a matter of sticking it out. Yeah, and I guess recognizing the name of a chapter in one of my books is knowing when to hold them and when to fold them, and when you sort of know when you really can stick it out, and when it's time to, if you're getting hurt, it's time to withdraw.
And do individuals improve over time, their partner, or more of these interventions like DBT, or all of it?
I think all of it. Some of it's even maturity. Um, maybe the cutting on oneself. As a person gets older, they may not need that. Some of the suicidal feelings may no longer be there. If they are able to get into a relationship, the tendency to begin to see the gray a little bit more, the tendency to have better control over anger might get better as a person ages. Um, I mean, I've had some pediatricians tell me they can recognize it in children. but usually you don't make a diagnosis until adolescence. And you have to understand the difference because for some people, the idea of adolescent borderline is almost a redundancy because adolescents are dealing with identity and moodiness and who they are and a sense of what they believe in. Um, but the difference, of course, is in the severity of it. And then as that individual gets older and maybe gets into work, into a consistent job and is able to maintain some consistency in their life, and now they're 30 years old and 40 years old and 50 years old, and now things have sort of settled down.
And how long have you been working with individuals with borderline?
Um, Probably for most of my career, 40 years, and I think they really weren't identified um, until the 70s, and they weren't even in the DSM until the 80s. But I was always interested in these people that nobody else wanted to see. I mean, that is another problem that I think we have in our profession. Is if you asked a mental health professional, usually, what kind of individual with what diagnosis do you not want to see walking in the door? And for your next new patient, they won't say schizophrenia or psychotic bipolar. They'll say, "Oh, don't send me another borderline personality. They're going to call me all night. They never get better. They're impossible to treat. There's nothing you can do for them." All of which is wrong. There's a lot you can do, and I found that a lot of people didn't want to deal with them. And I found it just sort of being a constant object, just someone that they could yell at sometimes, and someone who wasn't going to abandon them, and someone who was still going to be there. That these were interesting and insightful, and people who could really be uh, very valuable to society and themselves.
And we spoke earlier about how borderline is primarily diagnosed in women, but men have it as well. In your practice, do you find that it presents in similar ways or is it slightly different?
They are in similar ways, but as I mentioned before, there's a bias. If I give you this example, this person has a fight with their partner, goes to the bar, gets drunk, picks a fight with somebody else in the bar, picks up a glass, throws it on the floor, breaks it, storms out of the bar, jumps in their car, goes speeding down the highway, gets stopped by the police, starts screaming at the police, burst out in expletives and cussing and then crying. If it's a man, the policeman's probably going to take him to jail and say this guy's an alcoholic. If it's a woman, he may take her to the emergency room where they're going to diagnose borderline personality. So there's this sort of bias, I think, that the behaviors are similar, and the defining criteria are similar. So, but they can kind of be skewed on how you see sort of stereotypical feminine or masculine kind of behavior.
And for someone who's newly diagnosed, whether they're coming to you or their loved one is coming to you and they have someone who was recently diagnosed, what do you typically recommend as the first steps?
I think the first step is trying to define what the specific issues are, and also recognizing that um, there may be there in fact usually is comorbid diagnoses. Borderline personality rarely stands alone. It's almost always associated with another disorder: depression, bipolar disorder, eating disorders, substance abuse, attention deficit disorder, anxiety disorders. There's almost always something else. So it's trying to make sure you see both, because either one can camouflage. The borderline symptoms can camouflage the idea that you're not learning that the person is an addict, or the alcohol problems that they're having is masking over the fact that they have personality issues, that as much as you treat this, you're not getting both. So I guess trying to see the global issue of things. Um, in terms of treatment approaches, medicines are not generally recommended, but because they're comorbid with other illnesses, usually you'll end up with some medicines maybe treating the depression. And there has been some indications that certain medicine, serotonin antidepressants in higher than usual doses kind of settle down some of the moods in some people. and very low doses of antipsychotic medicines or mood stabilizers stabilize some of the impulsivity in some cases. But the primary treatment is psychotherapy. Um, and the biggest part of that is kind of keeping the patient. So many borderline patients, again, will go from saying, oh, my last 4 therapists were terrible, but you're wonderful. You just know exactly who I am. I think you're terrific. And if you get too caught up in that, that's going to blow up pretty soon. Because that's how it'll start off. So I think it's a matter of keeping the patient, because so many will, once they get upset or disappointed, something will leave. So being able to kind of stay there. And there are specific types of therapy that have been shown to be really helpful. Um, and these are approaches such as dialectical behavioral treatment, which is a form of cognitive behavior where the individual is developing social skills. And there's schema-focused therapy where it's a matter of looking at patterns in their life, or mentalization-based treatment, which have to do with identity and beginning to think through why they have the feelings and behaviors they have and recognizing it in other people. And then another one is transference-focused therapy, which is an analytic type therapy that focuses more on relationships. So there are different types of treatment for different types of patients. They've all been shown to work really well. The problem is, first of all, one size doesn't fit all. One may work better for one than the other. And secondly, most of these require intensive training by a specialist who's only going to do that. And that may not help everybody. A fifth form that's been useful was developed called good psychiatric management. And that involves less intense kind of training, so more therapists can employ it and be available for more patients. But what it focuses on primarily is really education. This is a disorder you have. These are the symptoms. This is why it's there, and focusing kind of on how they're on self-control and day-to-day kind of problems.
So there's hope. There's hope for people.
Yes. And just like I said, being that person who's able to talk with them and deal with what essentially is good psychiatric management, is looking at the global individual and seeing what they need in terms of where you're focused, and not getting caught up because I was mentioning before, the projective identification is going to almost always occur when there's a close relationship with a therapist. They're going to start off wonderful, then they're going to be terrible. And there are going to be times when they're going to tell you you're the worst person in the world, and the session's going to end and you're going to say, I'm a terrible therapist. And other times they're going to say, oh, you're wonderful, you're wonderful. You're going to say, oh, I am so good. And the therapist has to keep this very clear, because you get caught up in some of those projections and eventually it's going to fail. It's more a matter of being able to reflect to them, you got mad at me and I understand why you got mad at me. And maybe that's okay that you got mad at me. And I'm glad you came back this week, because you were thinking maybe you weren't going to come back anymore.
There's one thing you wish everyone knew or understood about borderline personality disorder. What would it be?
I think it would be that these people are not hopeless. They will get better, and that they are very worthwhile people with many, many talents. That they're not violent um, bunny boilers, uh, like in the old movie of Fatal Attraction, that she was originally cited back when that movie came out in the 80s as sort of the classical borderline, who on the surface appears lovely and beautiful and interesting, and then is crazy and violent. That's not who they are.
Where can people go to learn more about your work, your books, and your resources?
I think the books are available in bookstores or Amazon or Barnes and Noble or things like that. There are a number of things in the media about it. I think you have to be careful so much with things in the media. That's the only issue there. That that you really want to stick with things that maybe have an association with a legitimate, maybe Mayo Clinic or um, NIMH, an agency that's useful. But there's now, gosh, a zillion books. Some of them again are not always reliable. I think you want to look at the um, credentials of people who are publishing things. But there is a lot of information out there, which is a lot better than it was years ago.
And this is why I was so excited to speak with you because I know you are one of the experts in the field on this. Well, thank you so much, Dr. Kreisman, for joining me. And thank you so much for being here.
Well, thank you, Scarlett. I enjoyed the time with you.
Thank you so much for listening to today's episode with Dr. Kreisman. I hope this conversation brought you more understanding and insight into borderline personality disorder. If this episode resonated with you, please share it with a friend. That helps the podcast reach more people who might benefit from these conversations. And if you want to explore more, Dr. Kreisman's books and resources are listed down below to dive in deeper. As always, thank you for being here, and until next time.